Okay, so going to be talking about echo terrors. So I'm going to start with the history. And we see here, long before echocardiography was used to diagnose valvular heart disease, a Greek young man presented to New York Hospital in November 1952 with significant shortness of breath, dizziness, and a loud murmur. He was diagnosed with what they called at the time familial xanthomatosis. And that's what it looks like. So initially people didn't know, familial hypercholesteremia at this time. They say familial xanthomatosis, the diagnosis. And you can see all the xanthomas and xanthelismas there. And several months later, the patient unfortunately died. And a pathological evaluation showed that the aortic valve was very stenotic. And you can only able to admit the tip of your finger down there. It's a really stenotic lesion. So, and it was rolled in and scarred, and there was numerous arthromas in the cusp and the sinus of the valve, and extended all the way to the ostium, the coronary. And this is how it looks like pathologically. And then when you look under the microscope, you see a lot of a lot of crystals deposited in foam cells, and it started from the base and goes all the way deeper structure of the valve. And when we look 50 years later to another example, a 20-year-old Saudi female was first allowed to our hospital. She had extensive xanthomas. Her LDL was 17, and she lived about 10 hours away from a hospital. So this is a typical case of what we see in our clinic. And this is her echocardiogram. So you can see at least moderate aortic regurgitation and significant and mild, probably mild, moderate mitral regurgitation, good LV function. The aortic valve is still opening. LV function is good, but you can see there's a lot of atherosclerosis in the aortic valves, the 5-chamber view. And the peak was only about 2.8 meters per second. So probably in the mild moderate range, but not significant. So 10 years later, what happened? Patient didn't follow up. Did not take any statins, did not refuse plasmapheresis or having a liver transplant, and she returned again with significant chest pain and shortness of breath. And now, if you look at the aortic valve, it's not opening at all. And the peak grading is 76/41. So what happened? Patient admitted, we suggested an angiogram and surgery. She refused both and walked home. Her sister follows with us in the clinic. She's now 42. She had a coronary artery bypass surgery. She had a Ross procedure. Her vertebral valve was replaced. She's a practicing nurse. When we asked her about her sister, unfortunately, she told us that when she went back home, she died, unfortunately. So valvular heart disease is a very common thing. You look at the study done in 2017 in 33 patients in this registry in Lebanon. Majority of patients, so 60% at least, have some sort of valvular heart disease. And we always focus on coronary heart disease, but valvular heart disease is a very important thing. In our own registry here, which is in about 37, we analyzed 37 patients that we followed in our clinic. Most of them are LDL receptor mutations. And the mean LDL is about 14. The Duke score is about 20 on average. And if we look at these patients, 30% had aortic valve replacement and 32% had CABG. So these are patients not who have disease. They already had surgeries by the time we're following them up in their clinic. So this is a really high burden of disease. You're talking the patient population with a mean age of 26, and 30% has aortic valve replacement already by now. So these are very sick. These are patients very sick. So, and if you look at the Duke criteria, so when you look at it, say definitive is 8% Ours is 20%, so 20% average. So, phenotypically and genetically definite. And of course, people have been talking so hypercholesterolemia in Gulf is the big one. A smaller portion is familial. The very small one is the homozygous. This is one of my patients who gave me, allowed us to use this for presentation purposes. This is xanthoma, this is Arcus cornealis. And these are other findings that we see typically in these patients. Genetics, of course, like was talked earlier, and much more detailed than this, of course, it's autosomal codominant, and you have heterozygous in one, but homozygous can be simple, double, compound, autosomal recessive, and of course, there's more sophisticated analysis to this. Familial hypercholesterolemia, the estimated prevalence, of course, is much higher than expected. So when we talk about 1 in 244, we know it's much more than that. If you see Dr. Khader Habib's Gulf countries, Dr. Habib's registry 5 Arabian Gulf countries, it's about 0.9, so 1 in 112. Very important collaborative paper that we saw repeated multiple times today. So the willingness of the patient to do what needs to be done doesn't mean it's an easy task. So the course could be very complicated. So even if the patient is really compliant, wants to do what needs to be done, it is not an easy road. So if we look at this patient, 23-year-old female, was first evaluated for shortness of breath and chest pain. Her younger 2 brothers also follow with us in our clinic. Her initial LDL was 18. She has xanthomas with variable places and a really loud systolic murmur. This is her initial echo. The aortic valve just doesn't open. Doesn't open at all. Really bad hypertrophy and significant regurgitation. And also mitral regurgitation as well. And look at the peak gradient is 114/68. So the mean is 68. So this is really significant. So, and here you have significant reversal, so severe regurgitation as well. So intraoperatively, so a patient comes in, does all the treatment. Intraoperatively, there was significant supraaortic narrowing. And you look at here, it looks like what we call an hourglass appearance. So it's really significant stenosis just above the aortic valve. It was a very difficult surgery. So the aortic was heavily calcified, thick, filled with John's material. 3 leaflet was distorted, heavily calcified. Annulus was very small. All these are very disastrous. And like we talked when we first started, even the little finger can't be adjusted through this aortic valve. So a pericardial patch was attempted to augment the LVOT, and since 90 mechanical valve was sutured, and it was fairly long surgery. Cross clamp was about 176 minutes. But if you see immediately post-op, immediately, the pre-gradient is 70/40. This is immediately post-op. So these are not easy surgeries. And clinically, although she recovered fairly well, she became asymptomatic. She started on apheresis and able to exercise, started a new job. And she was closely followed in clinic. She again started having, 6 years later, started having shortness of breath and inability to exercise intolerance. And an urgent echo was repeated. When we repeated the echo again, you again have a gradient of 100/60. So another surgery was done. This time it was even more difficult. So a Pinta procedure was planned with mitral valve replacement, and it was just a difficult, extensive adhesions, ventricle very hypertrophied. When you tried, they actually had to cool the patient to 18 degrees and hypothermic difficulty arrest. So they're able actually to get ahead and do the surgery. And it was transected, and then eventually they were able to find a healthy tissue that they cross-clamp. So, they did the cannula, did the surgery, but even when they did the surgery, even the coronary was a difficult thing. So they couldn't worry, after post-operatively, it was a very slit-like coronary. So they actually had to go ahead and do, intracoronary dilatation and stenting in the surgery. Post-operatively, she did well. She stayed a month in the hospital, improved residual symptoms, and then she continues. And post-operatively, the LV function was good. No more aortic valve replacement, no more aortic stenosis. But again, she still having recurrent chest pain. And a balloon echo showed no changes in the LV function. Angiogram showed stent 3 stenosis. So this is an ongoing thing. So the idea that if you just treat them, they'll not have coronary disease, not have valvular disease, they're very complex. And they need to be in a system that are able to do very high level sophisticated surgeries. Okay, so why have a specialized clinic to follow these patients? You need a cardiologist, you need endocrinologists, you need liver transplant surgeons, you need lipidologists, you need nutritionists, you need everybody to interact together so you can be able to deliver care. And we know that these patients, if left alone, they probably die at age 18, but as you start treating them better treatments, their chances of survival increase. So in our clinic, about the majority of, most of our patients are on isotrol, high-dose statins, about 30% of PCSK9 inhibitors, and 70% is apheresis. This is the first person who did liver transplant in 1963, but he's the first person also who did a liver transplant for a patient who has homozygous familial hypercholesterolemia. And that was a proof of concept that showed us this is the problem, and that's why. Unfortunately, this little child who had the liver transplant died from heart failure because she had liver and heart, and unfortunately 4 years later, our immunosuppression therapy was not good. We know that after liver transplantation, LDL really goes down significantly post-operatively. But if you follow them long enough, for 10 years or so, the LDL starts to go back again, start to rise again. So these are not patients you just do a liver transplant and leave them in the wild. You have to make sure you pay attention to them and treat them aggressively if needed. And plasmapheresis also, we know, is very effective in reducing LDL post, but of course it has this yo-yo effect that goes up and down, and it's not something that you can is easily treated. New treatments like lamotrigine is also seen, and it's effective in lowering LDL. And here in Saudi Arabia, experience that showed that lamotrigine really reduces LDL and sustain, as long as the patient takes the medication, of course. And this is also seen in our 2 patients that we treated. Also, you see significant reduction in LDL as long as they are on treatment and if they can tolerate the treatment. So these are the issues we need to do. Evinacumab is a new medication for homozygous familial hypercholesterolemia. It has not been seen here. We haven't used it in Saudi Arabia. It just got FDA approved, but we haven't used it yet. And we was talking about earlier, significant reduction in LDL, and that's regardless of the LDL receptor function. So who should be in a clinic? Homozygous familial hypercholesterolemia, patients with complex heterozygous, and probably hyperprimary triglyceridemia who have recurrent pancreatitis. Low-risk patients might not be a good candidates for this highly specialized clinic and probably could be treated in the community. Conclusions: homozygous familial hypercholesterolemia is a fatal disease requiring special attention. It's not just coronary heart disease, it's also valvular heart disease, and valvular heart disease is very complex. It's much more common in the Gulf region than once thought. Valvular heart disease is under-recognized, but common and serious, very complex to treat. Echocardiography is essential tool to diagnose and treat these patients. Surgical interventions are more complex, higher risk of mortality, morbidity. We need to have specialized centers to do that. Specialized clinic can help coordinate multidisciplinary approach needed for high-risk individuals. And thank you for everything. And with this, I think we're done.